Morning, everyone. Welcome back to my IVF Answers and our webinars. And tonight we do have a special guest. She is back with us. I am very, very excited to have you back. This is Dr. Alejandra Aguilar, and she's been with us before. And hello, how are you feeling? It's wonderful to have you back here.
Thank you very much, Karen. I'm very excited to stay here for this tonight.
Lovely to have you back. And let me just mention that, of course, we will talk about advanced maternal age. And of course, Dr. Aguilar is here to explain all about this. And also, she has prepared one very special case, and she will discuss this today. She will start with the case, of course. And as you know, all our webinars are focused on success stories. And tonight, it's definitely, I hope I did see it already, so I can tell you that it's always inspiring to see those real life cases, and of course those amazing outcomes as well. So I do believe that you will find it interesting. But as always, remember, there will be time for your questions. You can put them whenever you want. So you can either put them in the chat section during the presentation or after the presentation, and we will have the Q&A time, so we will have definitely time for your questions. So don't hesitate. This is the option for your if you want to find out anything, Dr. Aguilar is right here to help you. I'm sure she will do a great job as always.
Sure.
And also, let me just mention that Dr. Alejandra, she is the gynecologist at the clinic in Valencia. The clinic is called Equipo Juana Crespo. As I've mentioned, there are some previous webinars you've done. I think there were like 5 or maybe even more. I don't remember exactly. But it's always interesting. I know that those sessions are always amazing, and I'm glad that we will be able to discuss this topic tonight with you. So I guess that is it. Remember, this is being recorded, and right now, let's begin with our presentation tonight, okay?
Okay, thank you very much, Caroline.
Thank you so much indeed.
Okay, so let's start, okay? Today's topic is about successful pregnancy in advanced maternal age, and regarding as well the implications of the advanced maternal age in fertility, okay? So let's start with the study case. This was a Spanish couple, okay, who came in our clinic. She was 40 years old without any pregnancies, and they were looking for a pregnancy for at least 3 years, okay? Her periods were regular, but she suffered from severe dysmenorrhea, which is painful periods, okay? And also dyspareunia, which is pain with the sexual intercourse, okay? She was diagnosed with endometriosis in 2016, okay? But nobody told her that the endometriosis could have severe implications in their posterior fertility, okay? Nobody told her, and she was psychologically super affected because of her infertility and because of her painful periods, okay? Regarding the male, he was 30 years old, a healthy boy, and his sperm analysis was normal, and sometimes other semen analysis show that it was with oligospermia, which is a low quantity of spermatozoids, okay? They did previous treatments in a public hospital in Spain. The first treatment was done in December 2018. They performed a short protocol in which they retrieved 8 eggs, okay? 6 were fertilized, and they transferred 2 embryos on day 3, and the rest were vitrified, okay? It's important to know that the transfer was very difficult. The technique was very difficult, and it was painful, and they need forces to do it, okay? This is very important because an embryo transfer should be done in perfect condition, means without pain, without bleeding, because if there is bleeding or with this pain, probably the pregnancy will be negative, okay? So we need to do, prior any embryo transfer, a trial transfer, okay? No, she didn't got pregnant, and in February 2019 they performed an embryo transfer in a substitute cycle with patches. They transferred the two remaining day 3 embryos, and she didn't got pregnant. So in November 2019, they performed a second cycle in which they retrieve 8 eggs and they vitrified 2 day 3 embryos. Okay, they didn't perform a fresh embryo transfer because the patient required so. Okay, she didn't feel well after the collection, so that's why they vitrified the embryos. And in a couple of months later, they transfer those remaining embryos in a substitute cycle with estrogen pills, and she did got pregnant. After that, they performed an hysteroscopy just to check the endometrium, and it was normal. The biopsy showed that there was no endometritis, and they performed a karyotype and a thrombotic risk profile, which they both were normal. Okay, so this is the general description of the case. And now, once the woman came to us, okay, we did an examination, okay, we did a vaginal examination, and we saw that the uterus was super fixed and it was very painful, okay. The ultrasound scan in the luteal phase show a swollen uterus with diffuse adenomyosis, okay. The endometrial thickness was very, very thin, measuring 18 millimeters, okay. And in both ovaries, we saw 2 endometriomas, okay, and 3 antral follicles in each ovary, okay, which was a low ovarian reserve, okay. And as well, we can appreciate in the ultrasound scan an endometrial node in the left uterosacral ligament, okay. So take into account this ultrasound examination and these previous treatments, we could do a diagnosis, we can make a diagnosis of deep endometriosis, adenomyosis, low ovarian reserve, and a possible male factor due to his previous sperm analysis showing oligospermia. Good. After the first visit, we made a plan. Okay, this plan was done during the first consultation. Okay, of course, through all the treatment, this plan can change if we find something different or we find something new. But this plan was done and was given in the first consultation. Okay, so the first thing that we have to do is to improve the oocyte quality. Okay, because we know that it's a woman of advanced maternal age with a low ovarian reserve and with low and with endometriosis. So we start giving her vitamins, antioxidants, and of course, we told her to lose a couple of kilos, okay, because her BMI was 26, so it's better if she lose a little bit of weight, okay. Then, secondly, we start planifying an IVF treatment. Okay, it was a personalized protocol, and it was a short protocol with letrozole. Okay, the letrozole is an inhibitor of the aromatase. Okay, it decreases the estrogen levels, and for people with endometriosis, it is good because the estrogens can affect the uterus. Okay, so we use this letrozole just for a couple of days during the stimulation to decrease her estrogens, her blood estrogens, and also the letrozole makes increase the FSH and LH levels, so it can help to the stimulation. Okay, and it was a short protocol using recombinant FSH and menopur. Then once we have enough embryos, we start studying the uterus and the fallopian tubes, because people with endometriosis, the vast majority of people with endometriosis, they have affected the uterus and the fallopian tubes. In the ultrasound scan, we have already seen that she had adenomyosis, and also we need to see if there is a problem with her fallopian tubes. Okay, if it's that the case, the fourth step is to treat that, and the last step, once we have everything solved, to do a transfer. We plan to perform a transfer in a substitute cycle with low doses of estrogens, because once we saw the scan in the luteal phase, the her endometrial thickness was very, very thick. So we prefer to have a thin endometrium. Okay, of course, this plan, as I told you, it can be modified through all the cycle. Good. So we start the first simulation in December 2020. Okay, the estrogens level, the estrogen and FSH level after stopping the contraceptive pill. We use the contraceptive pill to decrease the FSH levels and to make the ovaries resting, to have a better synchronic cycle. Okay, so the estradiol and FSH level were okay. So it means that we can start with the stimulation, and we got 5 eggs, and we only got at the end one day 3 embryo, only a single one. Okay, the rest we tried to reach the into blastocyst stage, but there was no evolution. Okay. After that, the patient, she did an MRI in the luteal phase just a couple of days after the egg collection. And this MRI, it shows an anteverted uterus with a normal endometrial thickness. We saw the endometriomas and a thickened junction zone in the fundus and the anterior wall. I will show you the pictures. Okay, this is a sign of adenomyosis. And surprisingly, in the hysterosalpingography, which it was done once she got her period, it showed her right hydrosalpinx, but it was patent, and a distal blockage of the left tube. Okay, here in the images you can see that there is a right hydrosalpinx. Okay, although it's patent, it was a very, very, very thick and swollen fallopian tube, and on the left there was a blockage. Like we see that there is no contrast in this area. Okay, so it means that as we expected, because of the endometriosis, the vast majority of people with advanced endometriosis, her fallopian tubes are blocked or can show hydrosalpinx. It means that we were right to ask for this test. This is the MRI. Okay, in the sagittal view, it was not a very bad uterus. Okay, contrary to the scan show a worse uterus than the MRI. But we can see here that the walls were a little bit swollen. It was a big uterus. Normally the walls should be between 1 centimeter and a half, and this was almost 3 centimeters. Okay, and the junctional zone, which is this black area surrounding the endometrium, was very thick. Normally it should be under 6 millimeters, and this was more or less 10 millimeters. And this is a sign of adenomyosis. Okay, good. After that, as we only got one embryo, we decided to perform a second stimulation. Okay, it was exactly the same protocol that the previous one, but then in that case we got 2 beautiful day 3 embryos in a very good quality, and 1 blastocyst in a medium low quality. Okay. The patient wanted to do a third stimulation because she wanted to have as many embryos as possible. So we did a third stimulation in March 2021, and we got 2 beautiful day 3 embryos. And that time we got 2 blastocysts, 1 day 5 and 1 day 6 blastocysts. So in total we got 5 day 3 embryos and 3 blastocysts. After that, we told her that we thought that we had enough for her. So we start with the treatment of the uterus and the fallopian tube, which we plan for the surgery. Okay, in May 2021, we did in the same day the hysteroscopy. The hysteroscopy was done to remove all the fibrosis and to increase the implantation area, to make some different cuts to improve the vascularization of the uterus and to improve the implantation. Okay, and during the same act, we did a laparoscopy to remove both fallopian tubes, the endometriomas, and the uterosacral node. The findings were as we expected: a bilateral hydrosalpinx, a uterine fibroid, a very small uterine fibroid, which was also removed, and severe adherential syndrome, and a deep endometriosis, which a vaginal node. Okay. These are images of the laparoscopy. Okay. After the surgery, we injected her a quarterly decapeptyl. Okay, the decapeptyl is an analog of the GnRH. Okay, is the treatment of the endometriosis. Okay, because it makes the ovary resting, it makes the woman be in for at least 3 months, it may be menopausal. Okay, because we need to understand that the endometriosis is an estrogen-dependent pathology. Okay, so if there is estrogen, it means there is periods, if there is ovulation, the endometriosis can get worse. Okay, so that's why we decide to treat her uterus with this quarterly decapeptyl. Well, 3 months later, we start her endometrial preparation, okay, with, as I told you before, with the low doses of estrogens. We need to take into account that in the normal preparation, in a normal woman, the doses are more or less between 4 and 6 milligrams of estrogens. In that case, we decide to give her only 2 milligrams. After 8 days of uterine preparation, we did an ultrasound scan, and the endometrium was super beautiful, and we decided to go ahead with the embryo transfer. The embryo transfer, we did a double embryo transfer. Okay, it means that we decide to transfer 2 day 3 embryos of the second cycle, 2 beautiful day 3 embryos, and a blastocyst of the third cycle. Okay, it means that we put 3 embryos. Why? Because we need to take into account that it was a woman that she was previously transferred 6 day 3 embryos. Okay, she has endometriosis, she has 40 years old, so it means that among those 3 embryos, probably we will get 1 baby. Okay, so that's why sometimes people with endometriosis, people with pathological uterus, we need more embryos to get a pregnancy. Okay, and then 10 days later they did a pregnancy test, which was positive. Okay, and it was in September. We still are looking to her. And the pregnancy scan a couple of weeks later, this shows an evolutive single clinical pregnancy, and we could see also the heartbeat, and everything was going well. Good. So this case, okay, this is a very complete one, because we have to talk about endometriosis, we can talk about and its implication, we can talk about a low ovarian result, and we have to talk about the advanced maternal age. Okay, it's very important to understand that one of the most important factors for of the IVF treatment is the age of the woman. Okay, so the younger the woman, the higher probability of pregnancy. Okay, but this doesn't mean that women older than 38 years old cannot have babies with their own eggs. Of course not. Okay, but it's difficult. Okay, just we'll talk about quite a few minutes about advanced maternal age and its implications. Okay. Currently, nowadays, we are facing a delay in maternity. Okay, women are deciding to delay the maternity because of several reasons. The most frequent reason is because of work. Okay, now there is a greater incorporation of women at work, and also with greater role and integration in the political, social, and economic field. Okay, and sometimes this cause an absence of a stable partner. Okay, and also we can find medical reasons, for example, a cancer that needs to be treated with chemo or radiotherapy, and therefore they have to postpone maternity. Okay. So, and over the last decades, we are witnessing a delay in which the women have their first child. Okay, women now, the average, for example, in Spain, of having a first baby is around 33 years. Okay, and 50 years later, it was around 29. Okay, and this can have a severe implication, because the older the woman, the lower probability of pregnancy. Here we can see in the first graph that sorry, that after the age of 35 years old, 35, 36 years old, there is a decrease in the fertility, and therefore there is an increase in the infertility. Okay, after the age of 35, the prevalence of infertility increase drastically, and therefore there is a lot of women going ahead to assisted reproductive techniques. And what happened that? Okay, what are the cause of the decrease in fertility due to maternal age? The first cause is a decrease in the ovarian reserve. Okay, the ovarian reserve is the number of available eggs that a woman has at a given moment in her life, and is closely related to the potential to reproduce. There is normally with 1 and 2 millions of oocytes when a woman is born. Okay, but then among them only 400,000 will reach maturation and will reach the puberty. Okay, but among them only 400 will reach ovulation. Okay, so it's very, very, very low. The rest of them, they reach atresia. Okay, so in a single menstrual cycle, for example, there is a follicular recruitment, but among them, only one will be in charge of releasing the oocyte. And if there is no fertilization, 15 days later, the period comes, and the rest of the follicles, they die, and there is another follicular recruitment. Okay, so among all those follicles that are recruited, only one will grow. Okay, and the rest reach atresia. That's why we are witnessing a severe dropping in the quantity of eggs. Well, how can we measure the ovarian reserve? We have several tools to measure that. The first one is by doing a blood test and to measure the anti-Mullerian hormone. Okay, if this test show that this hormone is below 1.19 nanograms per milliliter, you are facing a low ovarian reserve. Okay. Another technique is to perform an ultrasound scan and to count the number of antral follicles. If we see that there is 3 or less oocytes in each ovary, it means that probably we will facing a low ovarian reserve. That was the woman of the case. We didn't perform an AMH test because we already knew, because of her previous treatments and because of the ultrasound scan, that she had a low ovarian reserve. And finally, we have the estradiol and the FSH levels on day 3 of the cycle. Okay, if the FSH levels are high, over 10 to 15 units, probably the woman is facing a low ovarian reserve. Okay, this increase in the FSH level is the first endocrine sign of reproductive aging. Okay, and it explains the accelerated depletion of the follicle, the shortening of the follicular phase, and the increase in the incidence of dizygotic twins. Okay. Okay, it's important also to understand that one of the main cause of low ovarian reserve is the age. Okay, the older the woman, the lower amount of eggs, but also we need to take into account other factors, all the cause of low ovarian reserve, which could be genetic disease, such as the X-fragile syndrome. Okay, some autoimmune disease, environmental factors, cancer treatment, chemoradiotherapy are gonadotoxins that can provoke a decrease in the ovarian reserve, ovarian surgery, or the ovarian surgery due to endometriosis, or of course there is idiopathic means that we don't know the cause. Okay, just a quick view of that. Well, and it's very important to diagnose a low ovarian reserve because most women with low ovarian reserve, they don't know it. Okay, and if they look for a pregnancy at the age of 30 to 35 years old, they will probably succeed. Okay, but if the women want to delay the pregnancy over the age of 35, sometimes they can struggle, and therefore it's frequent the use of the assisted reproductive techniques. So I always tell that any woman who wants to delay motherhood, she needs to previously study her ovarian reserve. Okay, so it's very important to planify the family. Okay, to plan how many children she wants. Okay, because the age and the low ovarian reserve represents a major challenge in reproductive medicine, as it's often associated with a poor stimulation response, high cycle cancellation rate and a low pregnancy rate. We saw that in the first stimulation of the study case, we only got one embryo. Okay, of course here we don't do fresh embryo transfer if it's an endometriosis woman, because of course we suspected to have the fallopian tube blocked, and we wanted to treat the uterus, so we will never do a fresh embryo transfer. So in that case, it is better to accumulate embryos, and once we have a good pool of embryos, we start transferring these ones. Okay, but the low ovarian reserve, sometimes we have a poor stimulation response. Okay, having a low ovarian reserve doesn't necessarily mean that conception is impossible. Of course not. Okay, but it leads to an increase in FSH levels, and this is cause an impaired oocyte quality and a decreased number of follicles that are ready to be stimulated. So it's super important to perform screening. Okay, well, and now we will talk about the second cause. The first cause was a decrease in the ovarian reserve, and now the second cause is a decrease in the oocyte quality. Okay, the older the woman, the lower amount of eggs and the lower quality of them. Okay, here in this graph you can see that the older the woman, okay, the higher probability of having abnormal oocyte. It means that with an incorrect number of chromosomes. Okay, if the woman has an incorrect number of chromosomes in their follicles, in their oocyte, sorry, then they can have embryos with an abnormal karyotype. Okay, and this will increase the implantation failure and increase the miscarriage rate. Okay, we should take into account that at the age of 40, at least 60% of the embryos generated will be abnormal. Okay, and what happens if we transfer an abnormal embryo? The most frequent thing that happens is that it doesn't implant, which will lead to an implantation failure. The second thing, she can have a miscarriage. Okay, and the third thing, and most important, is she can have a baby with a chromosomal abnormality, namely the Down syndrome. Okay, so it's very important to understand that. Good. And now, the third cause of decrease in fertility by maternal age is the uterus. Okay, the uterus ages as well. It's like the ovaries get worse with the age, and the uterus as well. Okay, and a woman with advanced maternal age, she can have a decrease of vascular perfusion, an increase of myomatosis and adenomyosis, and also endometriosis, which we saw in the previous study. And this plays a negative role in fertility in older women. Okay, and also there is a a higher incidence of luteal phase deficiency. Okay, but however, the endometrium remains stable through the age. Okay, we are talking about the walls of the uterus. The endometrium normally stays fine. Okay, and also just to mention that with the age, with increased age, there is a decrease in of the frequency of the sexual intercourse. So that's why people they do not have sex as much as when they were younger. So this can also difficult the pregnancy. Good. And just older women also, they can have a higher risk of obstetric complication. Okay, they have higher risk of gestational diabetes, hypertensive disorders such as preeclampsia, placenta previa, and placenta abruption. They have also double risk of instrumental delivery, a preterm delivery, small for gestational age, and also for fetal death. So we need to take into account that. So what should we do? Okay, once we see that we are facing a woman, an older woman. Okay, the first thing is the prevention. Okay, so if we are in a routine gynecological checkup, okay, if we are gynecologists and we see that the woman wants to delay fertility and we see that her ovarian reserve is low, we should refer her to a clinic, to a fertility clinic, just to advise her and because she needs to be aware of the situation. Okay, if she wants to postpone motherhood, we can offer her an oocyte or embryo vitrification. Okay. On the other hand, if we are treating a couple, infertile couple, there are specific treatment for this case. Okay, with older women, we need to do a fertility treatment. Once exactly what that we did with the woman in the study case. Okay, vitamins, antioxidants. If she has a very low ovarian reserve, we can give her androgen pre-treatment with androgens. In fact, there is a lot of treatments. Okay, it's super important to personalize the stimulation protocols, because it's not the same to treat an older woman with a polycystic ovary than an older woman with a very low ovarian reserve. It's different. Okay, so we need to stimulate differently. Every woman is unique. Okay, everyone has his own previous treatment, his different BMI, his different oocytes, so we need to do personalized ovarian stimulation. Okay, we can use short protocols, long protocols, mild stimulations. I mean, but we need to use the best for the woman. Okay, we can also, if we are facing a low ovarian state, to perform an embryo accumulation. And once we have enough embryos, at least 2-3 embryos, we can go ahead with the embryo transfer. And we can also, if there is a very severe advanced maternal age, over the age of 42, my advice is, of course, to do the PGTA, okay, the pre-implantational genetic testing, just to be sure that we transfer a normal embryo, and therefore to avoid implantation failure or miscarriage. Okay. Then, if we see that this treatment is not successful, we have experimental treatments such as the ovarian rejuvenation, but this is done only in context of research. Okay, or in our clinic we are starting doing right now. Okay, and also with the ovarian plasma-rich platelet infusion. Okay. At the end, if no one of those techniques have been successful, of course, we will need to go ahead with an egg donation. Good. So to conclude, we've seen that the delay of maternity, there is a delay in the maternity due to several factors, okay, and this leads to an increase in the infertility. Okay, there is an increase in women who have the first child at the age of 35 or even older. Okay, and we need to take into account that the number and quality of oocyte gets worse with the age, exactly the same as the uterus and also the sperm. We don't have to forget that the sperm also can get worse. Okay, and also we've seen that there is an increase in the obstetric complication with the age, and a good solution if we want to delay fertility in women or younger than 35, that will be the ideal case, is the oocyte vitrification, or if they are in a couple, of course, the oocyte embryo vitrification. Okay, and as I told you before, it's very important to use personalized protocols, taking into account the characteristics of the patient. Good, and I think it's time for the questions if you want.
As always, amazing presentation. Thank you so much.
Thank you so much.
And it's always great to listen to what you have prepared. And of course, you have explained everything very thoroughly. Thanks a lot. And
you.
of course, now you are right. It's time for your questions. So if you haven't asked yet, because Dr. Aguilar, probably you see that there are many questions here. But if you haven't asked your question, this is your time. Go ahead, type those in the chat section, and let's have a look. Okay, we have plenty of those, so let's have a look at the first one. Is there a limit of months to use letrozole? Could it have bad side effects? And did you get, sorry, letrozole keeps endometriosis lower in those months? Is it true?
You're right. That letrozole keeps endometriosis lower in those months. Okay, currently we use the letrozole only for the stimulation. Okay, only for 5 days. During the first 5 days of the stimulation, we use the letrozole. Okay, because the letrozole, which will maintain the endometrial thickness. Okay, and it can also increase the size of the follicles in older women. Okay, we don't use the letrozole for more than 5 days. Sometimes, of course, the letrozole is used also in patients with have breast cancer. We have breast cancer and we need to stimulate people with breast cancer, we maintain the letrozole, but only for the stimulation. Okay, we don't use the letrozole for months. We use the letrozole in people which have severe adenomyosis, and we need to this is a complement of the capeptil. We use letrozole for at least 15 days or a month, but no more than that, because it doesn't mean that it has bad effects, but we don't like to use that so much, because it has not been demonstrated that it can help. No, with that kind of period, it will be fine, because we have good results with this time framing.
All right. Thanks so much for the very first question and your help with this as well. Next question, a bit of a longer question as well, and with lots of details. So let's have a look at this. Sorry, cannot see it yet. Okay, sorry, here. I'm 41 and have done few IVF procedures this year, have frozen 2 embryos. Whilst I was taking the fertility treatments, my periods were regular, generally before that as well. However, after I finished my last IVF round in July this year, my periods became irregular and I have had no period for 2 months. And now I just have some brown discharge, no period. Is this normal? Do you think it might be a sign of perimenopause? Could I continue with another IVF round before implanting the embryos? My AMH was 3.59 picomoles last year in March.
Okay. So Christina, first of all, good luck. Okay, of those three embryos. Of course, after an IVF treatment, you can have some irregularities in the periods. Okay, but it's important to understand that after the age of 40, there is a drastically drop in the ovarian reserve. Okay, and sometimes, yes, it can be a sign of perimenopause, but we don't know. The only thing to know is to perform a ultrasound scan or a blood test to check your FSH and estrogens level. Okay, if it was that, okay, don't worry, because we can still going ahead with an IVF round. Okay, we your AMH, it's low. Okay, it's very low, but it doesn't mean that we won't have any eggs. Okay, but yes, it's completely normal that after stimulation, the periods, the first 2 months after stimulation, it can be irregular or it can be heavier, that fat. Okay, but there is no issues. Okay, it doesn't mean that of course, if you feel that you have hot flushes, it means that your FSH level are very, very, very high and your estrogen is very, very low. But it doesn't mean that just by knowing where we are. Okay, if we know that your FSH level is very high, we'll try to use a protocol to decrease this FSH level to get as many eggs as possible.
All right. I believe this is very clear. Thank you so much for that
Thank
advice, of course. So best way is just to check your levels, yes? To find out, to make sure. All right, thank you. And let's have a look. Maria has another question for you. Should I do hysteroscopy after 2 failed frozen embryo transfer, 0 HSG, and a thin lining? I had an ovarian cyst in the past. Would I need to be asleep, big surgery, or is it enough to do a light version and then decide if I need to do the big one?
Okay, the first thing that we have to understand is we need to understand why you had to fail embryo transfer. Okay, because here in the clinic we need to understand, the first thing that we need to understand when we see an infertile couple in the first consultation is why she doesn't get pregnant. Why at home she doesn't get pregnant? Is because of the male factors, because of her endometriosis. So in that case, in the study case, we understand just in the first consultation, and we knew that she didn't get pregnant because she had a deep endometriosis and a possible male factor, and of course an advanced maternal age. Okay, so in that case, okay, I'm seeing that your embryos were uploaded. In that case, it's important to understand. Okay, so the implantation failure, if the embryo were uploaded, having a normal embryo, it doesn't guarantee 100% a pregnancy. So we need to understand that. Okay, because the embryo, the quality of the embryo is also important. The embryo has suffered a biopsy, and sometimes a low quality embryo that suffers a biopsy and then a frozen and a thawing technique, sometimes we can rest rest a potential implantation. Okay, so we need to check how were the quality of the embryos. Okay, and of course it's mandatory to check the fallopian tubes and to check the uterus. Okay, the hysteroscopy is a technique here. Is we use as a diagnostic technique, but we take advantage of that we are inside the uterus to try to widen the endometrial cavity, to make this uterus more receptive. So not everybody can do this hysteroscopy. Doing an hysteroscopy is super easy. Everybody knows how to do an hysteroscopy, but doing it well and to perform an hysteroscopy to try to direct the embryo for this area to make him implant there, this is very difficult. Okay, so we have seen a lot of people that have been done hysteroscopies with bipolar energy that have suffered from a differential syndrome, for Ascendant syndrome because of hysteroscopy. So if in your clinic they are not experts in doing hysteroscopy, my advice is not to do it. Okay, but they need to check. First, a good option is to check with an MRI or with the hysterosalpingography if there is any problem that can lead to the implantation failure. And of course, is to check also your thrombotic risk profile if there is something wrong there.
Excellent. Again, thanks so much, of course, for that. And there is a thank you from Christina from the previous patient, and
You're
of course
welcome.
from Maria as well.
You're welcome.
And let's have a look. Okay, next question that we have here, also from Christina. I am due to try a long protocol this time with Diferelin, on cycle day 21, but I don't know when to start due to my irregular period spotting.
Okay, so one thing to check is to perform ultrasound scans just to confirm the ovulation. Okay, this is the first thing that you can do. If you don't have regular periods or you don't know if you are ovulating, they can give you the contraceptive pill, and therefore you can start with the Diferelin. Okay, normally we prefer not in a long protocol not to give the contraceptive pill, but sometimes in people with very irregular periods or people with polycystic ovaries that they have periods for 3-4 months, we give her the contraceptive pill, and therefore we can plan for the treatment. Okay, so just talk with your gynecologist and he will do the most convenient for you.
All right. Again, thanks so much. And let's have a look. One more question from Emma this time. I am trapped in a vicious circle. Sorry. I have a high BMI, hence I had get advice to have an IVF until I lose weight.
Yeah.
I am now 39 with frozen embryos from when I was 36. Should I lose weight before frozen embryo transfer, or given my advancing maternal age, give it a go? I'm worried that it won't work and I lose my younger embryos. I am stressed that I then eat to comfort myself, but this doesn't help. Any
Okay,
advice?
Emma. The first thing, don't be stressed. Okay, this is something that we should be aware. Okay, it's very simple to talk to a patient. Okay, you have to lose weight, but people not often. It's very simple. Okay, of course we need to know that a BMI over 32. Okay, it has been demonstrated that it decreased the fertility. Okay, it decreased the number of eggs, it decreased the probability of implantation, and increased the probability of miscarriage. Okay, but of course it's high. The age is the most important factor. Okay, hopefully you have embryos when you were 36. Okay, I don't know what is your BMI. Okay, if it was your first if it's that is your first embryo transfer, of course, and your BMI is lower than 32, I will try to transfer an embryo. Okay, if not, means that we need to focus on losing weight, go to an endocrinologist, just go and exercise yourself. Okay, because it's important. If, for example, you are worry about those only 3 embryos. You can do and also another stimulation to get as many embryos as possible. Okay, but from my point of view, we have a lot of people with high BMI, okay, that got pregnant as well, but they need to know that they have a 5% probability of bad luck in that case, okay. But take into account your BMI. If it's a BMI over 35, my recommendation is to lose weight. Otherwise, the results will be probably bad. Okay.
Thank you so much, of course, for yet another advice here.
Thank you.
Yeah, let's have a look. Emma, I'd like to
You're
thank you for
welcome.
that. Thank you so much. Okay, next question. I am 50, known small fibroids, recent hysteroscopy, and was given the go ahead to proceed to frozen embryo transfer with donor eggs, both unsuccessful. Only 2 blastocysts left. What would you advise for next transfer? I am on aspirin, Clexane, and prednisolone protocol. You mentioned 2 milligrams, of estrogen a day instead of 6. Also, could that help?
I mean, the dose of estrogen, it depends of every woman. Okay, the dose of estrogen is to make the endometrium to thick the endometrium. Okay, if we see that your endometrium is very very thick, it means that we need to decrease the dose of estrogen. If we see that the endometrium is not thick enough, we need to increase a little bit, or to change the way, or change the uterine preparation. Okay, if it was to embryo transfer with an egg donation, that we need to understand why you failed that. So it will be probably we are facing a uterine problem. Okay, of course we need to check the quality of the embryos, but I assume that as it was from an egg donor, the quality was fine. Okay, you only got two. You have to, so in the cycle, I assume that you got 4 blastocysts. Okay, and with 2 FET of a single embryo transfer probably. So you only have 2 blastocysts left. Okay, my advice, I know that you are 50 years old, and we always recommend to a single embryo transfer. Okay, but in that case that you have the only remaining blastocysts, which will be probably in the worst quality. Okay, it will be to transfer both of them. Okay, regarding the uterine preparation, of course, if they've done a 2 FET and they have not been successful, of course they need to change something. They need to change either the uterine preparation, you can go ahead with the natural cycle, or with different estrogens, with a different way of estrogen, vaginal estrogens, patches, I mean, wherever. Okay, there's a lot of uterine preparations. And also they need to study your uterus. Okay, if you have fibroids, we need to check where are those fibroids, if they are touching the endometrial lining, if they are close to the endometrial cavity. I mean, this is very important. Okay, we need to check also the fallopian tubes and also your thrombotic risk profile. Good luck.
Good luck, indeed. Thanks so much. And let's have a look. More questions are coming in. Next one, a short one this time. Do you recommend long protocol for very low AMH?
It depends of the woman. It depends. Okay, I will not never recommend a protocol without seeing any woman. Okay, for example, it has been demonstrated that a long protocol with women with a low ovarian reserve, it has good results. But in our clinic, okay, we like to personalize the protocols. Okay, and it depends also, because most of the women coming in our clinic, they had previous treatment, previous failed treatments. Okay, so what we do is if they have not been successful in those previous treatment, we need to change. So we won't do the same protocol as we did before. Okay, so we need to change, we need to do something different. Okay, and of course, if they got a very good number of embryos or oocytes in the previous treatment, we will repeat. I mean, we will copy the things that got success, and we will do differently if they had not been successful. Okay, so the type of protocol depends of the patient, of the characteristic of the patient, her ovarian reserve, her previous treatments, and her age, of course.
All right. Thanks so much again. Now we will have a bit of a longer question with lots of details. Let's have a look. I'm 40, have had one failed IVF cycle. I had an AMH level of 20, which I was told was high for my age.
Yeah.
For that reason, quite cautious approach was taken to the stimulation. Only 4 eggs were retrieved. 3 fertilized, 1 embryo reached day 5. We had a frozen embryo transfer because it was thought that it might be overstimulated and be at risk of ovarian hyperstimulation syndrome. But unfortunately, no pregnancy resulted. Now we're considering the flare procedure, but I am a bit concerned. Is this going from one extreme to the other? With an AMH level of 20, do you think the risk of OHSS with the flare procedure is high?
Okay, so in that case, okay, this is one of the things that happen a lot. Okay, when we see a polycystic ovary, okay, people are very afraid of the polycystic ovary, and sometimes they do the stimulation is very low, okay, and it doesn't. We don't have to be afraid of the polycystic ovary, okay. In your case, you have a very good ovarian reserve, okay. It means that we need to take advantage of that, okay. Of course, we won't give you super high doses of hormones, because we don't want to cause you a severe hyperstimulation syndrome, okay. But in that case, with an AMH of 20 to having only 4 eggs, it means that the stimulation was done very bad, okay. We need to take into account that the polycystic ovary needs the LH levels are very low, so it means that they need LH, they need, for example, menopur, okay, and we don't have to be afraid. In that case, they have changed to a long protocol. I think is a good solution, okay, because in your case, probably they gave you the capeptale, they gave you Hovitrel, so that's why you didn't reach the LH the LH level, okay, so that's why they retrieve only 4 eggs, okay, so that's why they decide to start with and to do a long protocol this time. I think that unfortunately, we in people with a polycystic ovary, the long protocol is very good, but of course some clinics they refuse to do it because of the risk of the overstimulation syndrome, okay. But of course, if we will vitrify eggs, if we perform a estradiol level in each follicular tracking scan, if we try to prevent this hyperstimulation syndrome, I think we will have good amount of eggs and therefore good amount of embryos, because with 40 years old, we need to take into account your AMH level, and for that we need to get as many eggs as possible, and therefore as many eggs and embryos as possible. In that case, my advice is if they have more than 4 blastocysts, it will be to do the PGS just to confirm that you have normal embryos, okay. But don't be afraid, okay. Of course, you will feel bloated, you can feel a bit of discomfort, but just for a couple of days. We have several pills, we have several drugs to decrease, to avoid this hyperstimulation syndrome, okay.
Thank you so much again, also for the reassurance here. Thank you so much indeed. And of course, as you can see, Amanda says thanks, and our previous
Welcome.
patient, Karen, as well. Okay, let's have a look. Okay, next question we have here. Do you think egg quality can be affected negatively for an older woman by using high dose of IVF drugs?
Yes, of course it can happen. Not that the quality can be dropped significantly, okay, but it has been demonstrated that in people with a low ovarian reserve and in older women, uh, it's given more than 300 units. It's a waste of money, and also it can prejudice the woman, because it can have worse events of events adverse events, okay, and it can also impair the uterine quality. Okay, so and it's important not to increase the dose in older women. Okay, of course, if the woman has a high BMI, we need to adjust this dose, but no more than 225 or 300 in that kind of patient.
Thanks so much, of course. Let's have a look. Okay. Next question is up from Claire. I am 40, having IVF on my own, and have had 4 failed IVF transfers, 1 fresh, 3 frozen. Last frozen transfer was with a different donor. 2-day 5 blastocysts were transferred. I have 3 frozen embryos left. I had an ERA cycle which showed my lining was early receptive, so my last cycle transfer was 12 hours later, but still was unsuccessful. What advice would you give me now for what to do? Would you advise any investigations before any other transfers?
Yes, of course, if they were blastocyst and it was from an egg donor, it means that there is something there. It means that there you have an implantation failure, and the reason is not the ERA test. Okay, the reason is beyond that. We need to check, of course, the uterus. Okay, by doing an MRI, by performing an hysteroscopy, just to rule out adenomyosis, to rule out endometriosis, to rule out endometritis, okay, which is inflammation or infection of the endometrium. Okay, and of course we need to check the fallopian tubes. The fallopian tubes are always super forgotten. Okay, and sometimes there is a hydrosalpinx or there is something wrong there that provokes this implantation failure. And once we remove these fallopian tubes, the woman got pregnant. Okay, so we need to study that, to study the uterus, to study the fallopian tubes. Okay, also to study your thrombotic risk profile, just to be sure that there is no any problem with your coagulation. Okay, but yes, we need to focus on that. Of course, it's important to check the quality of the embryos, or if those embryos were analyzed. Okay, if it was from egg donors, this is very but to check this donor. If the donor has previous pregnancy or previous cycles, we need to check if the donor had good embryo quality. Okay, but yes, it means that we need, once we have 2 failed embryo transfer, it means that there is something wrong, and we need to focus on different things, because it's not just embryo transfer, and we will wait for the luck. No, it means that we are doing something wrong, and we need to investigate in other ways to find this problem. I want my eggs with a stem donor. Okay, I'm sorry, I was confused. Okay, in that case, of course, it can be also an embryo quality. So in that case, the first thing is to perform the PGS to confirm that there is no that there is the embryos are normal. Because, for example, if we do a cycle and we see that the embryos are chromosomically abnormal, it means that we are facing a problem of the ovarian quality. Okay, so that's why the reason of their implantation failures. If we perform a cycle and you have normal embryos, it means that your previous embryo transfer was probably with normal embryos. So it means that we should investigate deeply in the other cause of implantation failure.
All right. Again, thanks so much indeed for
welcome.
that. Okay, there are like few questions left. We will be slowly finishing, but of course, if you have any questions more, go ahead, type those in. And we were talking about ERA in a minute ago, so let's have a look at this question. I'm planning on doing ERA after 2 failed frozen embryo transfers. Would you also recommend doing ALICE enema?
Okay. In our clinic, we don't use ERA test, okay, because it was a promising technique 10 years ago, okay, but now it has been demonstrated that it doesn't change anything, okay, because there's a lot of papers that confirms that the ERA test now, it doesn't increase the probability of pregnancy, okay, and we have a lot of patients that got this ERA test, and we decide to transfer the embryo when the patient was ready, and she got pregnant without taking into account the ERA test. I'm sorry. And so therefore, I do not recommend the ERA test because it won't change my plan. Okay. Of course, if they are planning to do an ERA test, you can do the Alice and Emma. Okay, it's a complementary technique. They can see the microbiota, which is completely fine, because if they see that there is something wrong, then they can give you probiotics, or if there is an infection, they will give you antibiotics. So if you are planning the ERA test, of course, in the same technique, they can also do the Alice and Emma. So go ahead.
Again, thanks so much indeed.
You're welcome.
And Maria also added something. Sorry, let me just go straight away to this one. Yeah. What would you recommend instead of the ERA test? Is there anything else, or shall I just skip it?
It's the ultrasound scan and the hysteroscopy. I mean, the eyes of the gynecologist and the experience of the gynecologist. Sometimes before, in our clinic, for example, before putting an embryo, okay, the day of the scheduling of the embryo transfer, we perform a diagnostic hysteroscopy, and we check the endometrium. If this endometrium is fine, okay, without signs of endometritis, with a good shape and good color, we are, for me, it's more reassuring than the ERA test, because the ERA test, okay, it analyzes a couple of genes. Okay, the endometrium, it changes every month. Every month you have new endometrium. Okay, so if you are pre-receptive in an endometrium, next month you don't know. Okay, so for me the best technique is, of course, the scan and the hysteroscopy, which will be, this endometrium will be in charge of allowing the pregnancy in the same in the same fertility cycle.
All right. And again, there's thank you from Maria for you. Okay, next question. Let me go back to this. Yeah, okay, this is the question. It was discovered that I had Hashimoto, which healed by itself. Now I only have a normal hypothyroidism for which I take medication and have a very good measured TSH level. Have my eggs already turned bad due to Hashimoto, or are there still good chances?
Do not worry, Bridget, because if your TSH level it's good now, it has a good level, your eggs will be completely normal. Okay, the hypothyroidism has not been related with a bad quality. Okay, the hypothyroidism can have implications during the pregnancy for the future baby, for the neural development of the baby. Okay, of course, a complete hypothyroidism disorder, okay, with a TSH level super high, of course it can compromise the fertility, because you can have alteration of the menstrual cycle. But if your periods are regular, don't worry, because it doesn't, your egg quality won't be affected because of TSH level.
All right. Thanks so much again for another reassurance here. And let's have a look. Possibly our final question. Okay, so let's have a look. Do you do the AGA pre-treatment in low ovarian reserve? And if yes, how long?
Yes, the answer is yes. Okay, it has been demonstrated that it can increase the oocyte number. Okay, in that case, with people with low ovarian reserve, every oocyte matters. Okay, so we used to give the HEA. Okay, we prefer the HEA than testosterone, because sometimes the testosterone can provoke ovarian cysts. Okay, which is not malignant, but we don't like. And we use the DHEA. It should be administered at least 21 days before the stimulation. Okay, so we start taking then the previous month to the stimulation, and they continue until we got embryos. Okay, so yes, the answer is yes. We normally we gave it.
Excellent. Again, thank you so much for this question. and of course for your help with that and all of the questions. As I've mentioned, it looks like that was our final question. So
Okay.
thank you everyone for being active here, for asking your questions with a lot of details, but also I believe that it's been very useful for you, Dr. Aguilar. Thank you so much
Thank
for
you.
your again, you have joined us and I'm glad that you did. And
Thank you.
of course, it's always great to have you. And thank you for helping out with those questions. And
Thank
as
you so
always,
much.
remember that this is a webinar where you can ask questions. But if anyone feels like you would like to get some more details, you can always get in touch with Dr. Aguilar, her team at Juana Crespo. I am sure they will be able to help you out and give you some more details as well.
Sure. If anyone wants me to help her and to answer some questions, of course, I will be me. I will be more than happy.
Wonderful. Thanks so much indeed.
You're
And
welcome.
remember, it has been recorded. So, anyone, if you missed any parts, you can always go to myivfnces.com, but also our YouTube channel. And there will be the webinar will be right there. It will be available tomorrow. So, you can check it tomorrow. And I can only encourage you to join us on Thursday. There's another webinar. It's again about advanced maternal age, more success stories. This time, Dr. Tsakos will be with us, so I hope you can join us and ask your questions and as well. And thank you so much, Dr. Aguilar. I'm looking forward
Thank
to
you.
some more webinars in the near future as well, as always.
Yes.
And of course, right now, take your time, relaxing time, I hope as well. And
Yes.
everyone, thanks a lot. It's been a great session indeed. Thank you for being here. And of course, I'm looking forward to see you here next time as well. Thank you. Have a lovely evening, everyone. Take care. Bye.
Thank you very much, Karen. I look forward to hear you soon.
See you soon. Bye.
Bye bye.